Hi everyone, I am Dr. Uğur Özkerim, a medical oncologist from Istanbul, Turkey. It's real pleasure to be here, 6th annual OncoAlert Colloquium. Today, I would like to share how I manage lung cancer in daily practice, especially when not all treatment options are available. Unfortunately, this is very common in real-world practice. What I'll talk about today is what not avail what not available actually means in real-world oncology, why waiting can sometimes be harmful, how I make treatment decision in daily practice, some real-world examples from Turkey, and finally how our approach to lung cancer evolving in 2025. What does not available really mean? When we talk about treatment, we often imagine ideal situations, but in daily practice, that's not always the case. Not available doesn't always mean a drug doesn't exist. It may mean we cannot access it in time, we can't afford it, or the patient is not fit enough to receive it. In practice, I usually see three common scenarios. One, biomarker results are delayed or missing. Sometimes we need to start treatment before results are available. Two, approved therapies are limited by access or reimbursement. Three, patients are not fit for the ideal option because of frailty or comorbidities. Why can waiting be harmful? Sometimes waiting feels reasonable. Maybe tumor burden is low or patient is stable. We might think it better to wait for the right drug, but in many cases waiting is risky. Performance status decline fast, symptoms can worsen, disease can spread, and we may lose the window of the future treatment altogether. By the time we are ready, the patient is not. How do we make best decision when the ideal treatment is not available? In daily practice, guidelines are helpful, but the patient in front of me comes first, and I ask myself three simple questions. Can the patient safely wait? Is the patient fit for ideal treatment? What is the best achievable option right now? If the patient has severe symptoms or organ-threatening disease, I don't wait for biomarker results. In the case, I go for fast cyto reduction and symptom control. I usually start chemotherapy. For example, carbo plus pemetrexed in non-squamous histology or carbo plus Taxol in squamous histology. This is about buying time, not replacing targeted therapy. Once the patient stabilizes, I adapt the plan. Sometimes the issue isn't access, it is risk. If a patient has transplant history or immunosuppressed, I may avoid immunotherapy altogether. And elderly or frail patient, I adjust chemotherapy intensity, dose reduction, weekly schedule, or single agent regimens. The goal is keep treatment going to safely. Of course, sometimes the real limitation isn't the patient. It is information we don't have. If tissue NGS isn't available, I try liquid biopsy. But if that also fails or gives no actionable results, I still have to make treatment decision based on what I do know. In non-squamous patient, especially when a targetable mutation is possible, I really try get enough tissue because good biopsy can change everything. But in heavy smokers with squamous histology, I am often more comfortable starting with chemotherapy. If we find a targetable mutation but cannot access the drug, I look for clinical trials. When the drug or clinical trial isn't available, I go with the best available systemic therapy, usually chemotherapy. If every time I start nine ideal treatment, I am already thinking one step ahead. The goal is keep the patient fit for the next line and always talk honestly with the patient about that. This is how access and reimbursement affect daily practice in Turkey. Actually, technically many approved drugs are available, but the real issue is reimbursement. For example, in the patient with high PD-L1 expression, we often cannot access chemoimmunotherapy combinations. So we end up choosing between chemotherapy or immunotherapy. And we make decision based on patient condition, urgency, and tumor burden. Targeted therapy is more complicated in real life. For common drivers like EGFR, ALK, ROS1, we can generally access first-line targeted therapy. But for others like MET, RED, HER2, the main issue is access and reimbursement. And because of that, we sometimes have to use chemotherapy even in the first line. Good example, osimertinib plus chemotherapy is not reimbursement in Turkey. And this challenge doesn't end up progression because access to newer drugs like amivantamab is very limited. So when the patient progressed after osimertinib or lorlatinib, chemotherapy is often the only real option. In small cell lung cancer, we generally follow the guidelines. First line chemotherapy plus PD-L1 inhibitor is standard. This combination accessible and generally well tolerated, but in later lines options become limited. New agents like lurbinectedin or tarlatamab look promising, but access is limited and toxicities are real concern. So many cases we use platinum rechallenge or standard second line chemotherapy. They may not be perfect, but sometimes they are the only feasible option. Practice changing in 2025. Actually, we have some real progress. We now have better access to molecular testing, immunotherapy, and targeted therapy, more experience managing toxicity, new option for resistance mutation. We are using antibody drug conjugates more often. And even though we have newer drugs, chemotherapy is still the backbone of treatment in many real-world situations. So to finish, these are the key take-home messages from daily practice. If I had to summarize everything in one sentence, don't delay treatment when the patient cannot wait, and always think one step ahead. Thank you for your attention.